Alrighty. Well, thank you so much, everyone, for being here today for this training on the foundations of harm reduction and housing first. For those of you that don't know me, I think I know a lot of you, but for those of you who don't know me, I'm Carla, and today I'm joined by my colleague Riley, who will also be co-facilitating this training. Our colleague Jillian is also on the call and is going to be kind of helping us monitor the chat and also available to support and answer questions. This is our second to last training in the training series that we're doing for Health Ambassador grantees. Tomorrow is the last training on sustainability planning. And just like with all the other trainings, the slides and the recording of this training will be shared as a follow-up. So don't worry about like screenshotting the slides or taking too many notes unless you want to, and that helps you. I will also say I am recovering from a cold, so if you see me just go on mute and drink some water, it's just because just to keep my voice here, but it's probably a good thing because I tend to talk very fast, and so it will make me slow down and actually talk at a normal pace. Also, we're going to go over a good amount of material in like a relatively short amount of time since we only have an hour. But as your questions come up, the chat is available for you to type out your questions and pop it in there. And our team is going to monitor the chat and get to your questions. If the chat is not available to you, like let's say you're calling in from a phone and you feel like you might forget your question if you wait, then please go ahead and unmute yourself and ask us your question, and we can either answer it there or we can save it for later. We can write it down and save it for later. And then we're also going to have a couple of chances during the presentation where we will pause and folks can ask questions too. So just keeping that in mind. And then any questions that we don't get to during this time, we can always follow up with you via email and send the response to your question to all of the folks who attended today's training. And just want to welcome also the folks, if anybody's here who's not a part of a Health Ambassador program, but you're part of an organization who does have that program, that's totally okay. Feel free to, for tomorrow's training on sustainability, any and all of your staff from your organizations can join these trainings. It's not just for folks who are participating in the Health Ambassador program. So first, we're going to begin with the Zoom poll. I'm not sure, Riley, if you're able to launch it for me. We'd love to know how familiar are each of you with harm reduction? So we'll keep this poll up for 2 minutes to give you all time to answer. It's going to be helpful for us to know how much time to spend on certain topics. And kind of gauge your knowledge on it or the level of comfortability that you have with this topic. So we'll just wait a minute or so more. Seems like a lot of you, your agency uses harm reduction as an approach. So that's awesome. We're excited to hear that and looking forward to hearing more about how you've used it and what challenges you've come across. A couple folks said, or one person said they're a little bit familiar with it. Somebody else said they're very familiar with it. But yeah, the majority of folks said that their agency actually uses harm reduction as an approach. So that's awesome. We've got experts in the room, which is great. So some of this, I'm going to go ahead and stop sharing. So some of this might be a little bit, I guess, like a review for some of you who do use harm reduction. We do have a slide a little bit later on that has some discussion questions. And I think it could be really helpful to hear from you all how you're utilizing harm reduction during that discussion, what challenges you might face. So we'll get into that so you'll have an opportunity to share. So we're going to answer 4 questions today, or at least that's what we're hoping. Number 1, what is harm reduction? Why harm reduction? How can you incorporate harm reduction approaches into your organization's work? So hopefully there we'll be able to share some strategies that maybe you're not currently using. And then what is housing first? So starting off with, what is harm reduction? Um, so although harm reduction is typically thought of as a structural approach, like policies or strategies like syringe exchange programs, harm reduction is also a relational approach. So what does that mean? It's a relational approach to care that can be implemented in outreach teams and healthcare to improve outcomes for folks who are oppressed and vulnerable, including those who are experiencing housing instability. And so that's operationalizing and using relational harm reduction care, such as pragmatism, autonomy, honoring the autonomy of your clients, and accountability without providers terminating patients from care are just some examples that harm reduction can be a relational approach. So we'll talk about some of those things today. And then these are a couple definitions that we pulled out of harm reduction of what it is. So I'm not necessarily going to read the whole definitions here, but feel free to. We do want to mention, though, that while harm reduction approach is often used in the context of substance use treatment and disorders, it is an approach that can be used in a broader context than that, right? And so even though these definitions do talk about it in relation to drug use, the harm reduction approach, like I said, can be used for other high-risk behaviors and in other situations. And the most important things to pull out from these definitions essentially is, first of all, harm reduction does not exist in opposition to the notion of abstinence and treatment. So harm reduction doesn't, focus on although it doesn't oppose, have like people completely stopping a high risk behavior, completely stopping engaging in a high risk behavior. It really focuses on providing options to a person. So abstinence or stopping that high risk behavior is not the only option, right? So people have a choice. And then since harm reduction is about choice, some people may choose not to quit or choose not to stop that high risk behavior. It doesn't mean that person might not choose to stop later. And so, like I said, this also applies to high risk behaviors other than substance use, which we'll talk a little bit later today about. But just focusing on like choice as being the main pillar of harm reduction, and you're truly meeting people where they are in their journey and providing a service based on what the individual expresses that they need in that moment. So, if you've heard of harm reduction before, or if your agency utilizes harm reduction or has a harm reduction program, chances are that maybe these are some of the examples that you have like heard of. So the needle exchange programs, distributing Narcan and naloxone to prevent to treat overdoses, right? Pre-exposure PrEP, I don't know how to say that last word, I apologize. Having hotlines for supervised use and education on the safer use of drugs. And so while all these examples of like the traditional harm reduction programs are all around the context of substance use, once again, harm reduction is not just for people using drugs. So we're going to go into like a few of the core principles of harm reduction. So like I've mentioned the last couple of slides, high risk behaviors can be drug use, but it can also be alcohol use. It can also be higher risk sexual activity, not taking needed medications, not taking COVID or other vaccines. So the important part in this principle is that harm reduction is pragmatic, meaning that you're focusing on where the person is now and what is feasible or realistic for them within the context of what they want and their goals, rather than focusing on the ultimate goal of getting them to stop completely engaging in that high risk behavior, right? And harm reduction also accepts that and notices that high risk behaviors are a fact of human society, and that many of the causes, and many of the engagement in high risk behaviors can sometimes be due to different social determinants of health. And I'm just going to mute myself for a second here. And then principle 2, the focus is on reducing harm, not reducing consumption. So, just as the name harm reduction suggests, you're not reducing the consumption or the amount of high risk behavior. We're really focusing on reducing harm. Next principle, choice. It is the individual's choice to manage or mitigate the risk of their high risk behaviors. So that really empowers the person to have ownership over their own actions and their choices. Next principle, the individual has a voice and deserves to be treated with dignity and respect. This goes back to the person, the person receives services, even if they're continuing the high risk behavior, and just recognizing that the person's opinion matters. They deserve to be heard. They know themselves better than anyone, right? And what might be their goals and their needs right now. Principle 5, individuals are expected to take responsibility for the natural consequences of their behavior. And so, just because you are using a harm reduction approach does not mean that, there's no accountability or consequences that person is going to, take responsibility for due to their engagement in high risk behavior. And then these are all the principles together on one slide, which might be helpful for folks to refer back to when we send out the slide deck. And then finally, when we talk about what is harm reduction, we also want to talk about who harm reduction is for. And essentially, due to its flexible approach, so you're meeting folks where they are, you're focusing on choice, and all of the principles that we just discussed, harm reduction strategies are appropriate for various different folks, right? For adults, for families and youth, and not just for people who are using drugs. So now I'm just going to pass it to Riley so she can answer the question, why harm reduction?
Thanks, Carla. And hey, everyone. If you haven't met me yet, I'm Riley Mead from Homebase. And yeah, this section is pretty brief, but just want to reflect on why we use harm reduction as an approach, why it's successful. And some of you, based on your work, you already kind of know this, but it's always important to kind of come back together and reflect about the big picture in your day-to-day implementation of Housing First. You're not maybe always thinking of these advantages of harm reduction and what is the end goal. So we hope this conversation helps you reflect on that. So on the next slide, this slide has kind of some specific cases as to why we implement harm reduction. But first, just want to generalize some of the advantages to a harm reduction approach. One being that it keeps the provider-client relationship intact despite maybe setbacks that an individual has in their behaviors. It also, harm reduction is advantageous because it increases client ownership and control over their own behaviors and their treatment choices. It also empowers clients through experience of incremental success, meaning understanding that change is gradual for individuals and success doesn't look like necessarily sobriety or not. Success can be gradual. So harm reduction acknowledges those incremental changes that are worth acknowledging and empowering clients through. And also, harm reduction is advantageous because it reduces experiences of failure. It aims to set more realistic goals. Again, it's not about yes or no, are you engaging in this behavior? It's more about working towards what an individual wants to do to better their life and better themselves. So that's just some advantages to keep in mind. But on this slide, we have some more specific cases as to why we implement harm reduction. And putting the cart a little before the horse here, we have Housing First as a harm reduction strategy. And what you just need to know now is Housing First is an evidence-based successful approach to getting people experiencing homelessness housed by reducing as many barriers to housing as possible. And we're going to talk more about that Housing First in a bit. We have a section on that in this presentation today. But for some people, barriers to housing are their high-risk behaviors. And that's why I just wanted to call it out here. But moving on, harm reduction also has shown to lead to positive um, client outcomes in relation to their potential drug and alcohol use, as well as their overall health. So there's lots of research out there that you can find. Just want to highlight that research has shown that harm reduction can reduce injection of substances in public places, reduces sharing of needles, reduces injection frequency. Um, Research has also shown that harm reduction strategies can reduce rates of infection like HIV and hepatitis. It can reduce overdose deaths and other deaths associated with using substances and increases use of condoms. So there's there's a lot of evidence out there that we use harm reduction because it works. It really does help people improve their quality of life. Harm reduction also offers benefits to providers too. Providers who use a harm reduction approach report several positive impacts, like it helps eliminate tension between providers and um, participants that maybe have some setbacks, and it liberates providers from their responsibilities of their clients' behaviors. So we'll move to the next slide that kind of demonstrates how what characteristics of a harm reduction program facilitate those benefits and to clients and their providers. I just want to remind folks that harm reduction is not necessarily for people experiencing homelessness, but because that's our population we're talking about today, we'll be focusing on it in this context. But um, some characteristics of harm reduction programs is that it removes barriers to services and support. That's really, really key to this approach. Barriers could look like forced treatment, and also harm reduction programs focus on having non-coercive engagement and client-driven services, meaning clients really have use their power to engage in what services they like, and also have the ability to change their minds and change course of action about what services they want to engage in. Harm reduction also programs focus on immediate needs to ensure the safety of individuals as best as possible. And then information and education is critical too. So thinking about how clients need to be informed to make decisions about engaging in services in their life. Building relationships is also part of harm reduction programs. Oftentimes, people experiencing homelessness have reasons for mistrusting the healthcare system or the homeless system of care, but harm reduction can help rebuild those relationships by providing individualized care and support. And next, a big part of harm reduction is acknowledging personal responsibility. Ultimately, individuals are responsible for the consequences of their high-risk behaviors, and not in any way does harm reduction reward these behaviors. And then harm reduction programs often require partnership between homeless service providers, community-based organizations, healthcare systems and teams to kind of meet all the needs of individuals. And just want to end here on, for better, for worse, people are engaging in high-risk behaviors, and change can be really hard, and change can take a long time. And the characteristics on this slide here are proven to reduce the harm individuals may experience from something like substance abuse and help build trusting relationships between individuals and providers, and gets helps individuals get all the support they need, like not just related to their high-risk behaviors, but can help them get support to housing, mental health, mainstream benefits outside of just high-risk behaviors. So these benefits of implementing these characteristics may or may not seem intuitive to you, but just want to just stress that these are proven strategies. And on the next slide, we have some opportunity to reflect as a group. We want to kind of hear from you all, what does harm reduction approach or strategies look like in your organizations? Kind of think about how you're engaging with people experiencing homelessness and how harm reduction has been useful or you can see it being useful. And would love to hear from everyone in the chat. And if anyone also wants to come off mute and share, I think we have a little bit of time for that too. We'll give everyone a few minutes to put something in the chat. This is it's really helpful to kind of know where you all stand with harm reduction and how you see it benefiting the work you do, or maybe how it can be challenging in the work you do. Well, maybe you all can sit on it a little bit longer. We have another discussion activity, so we can come back to this question, but hoping to hear from you all as a group. But that's okay if folks are feeling like today is for sitting and listening. We're just happy to have you here. So I'll pass it back to Carla to finish out this conversation.
Thanks, Riley. So we're going to move now into what are ways to incorporate harm reduction into your work. And so keeping in mind, that like you all have shared, many of you in your organizations are likely already utilizing these strategies in practice and maybe just aren't calling it a harm reduction approach necessarily, right? So some of these are going to look very familiar to you as well, because some of these are the key characteristics that Riley shared about harm reduction. And these are just kind of ways to put those key characteristics of harm reduction into practice. So the first one is using non-coercive engagement. So what does that mean? Number one, you're communicating with clients respectfully and non-judgmentally. You're also using people first language. So people first language, if you're not familiar with that, that means saying people experiencing homelessness or people experiencing houselessness versus saying homeless people. Or you're saying, instead of saying an addict, you're saying a person who is in recovery, and et cetera. So there's a bunch of other examples. But essentially, it's acknowledging that, a person is a person first, and that, somebody's experiences or is not necessarily like their, identity or what they are. And then also accepting that it is the client's decision to engage in high-risk behaviors. And then lastly, utilizing motivational interviewing. Now, motivational interviewing is a whole separate thing. It could be a separate training, but essentially, just to kind of sum it up for the purposes of today, motivational interviewing is a collaborative and person-centered counseling style that really focuses on helping essentially clients like explore their motivations for behavior change and create space for them to explore and resolve their mixed feelings about that change. And we actually have a link in the resources slide later in this slide deck from the National Harm Reduction Coalition's website that talks about motivational interviewing and goes a little bit more into depth about what that can mean. Another characteristic that Riley touched on was ensuring that services are client-driven. And so what that can look like in practice is asking clients about their needs, their goals, and their capacity. clients or in case managers, or in some of your cases, outreach workers can work together to explore those options based on the client's needs and goals and capacity that they've identified, and then explore options that can fit within those 3 areas. And then lastly, utilizing a flexible array of interventions and avoiding coming into that conversation with a predetermined approach of what your client should do. And then giving the person options, right? And so while I know some of your programs, you might not necessarily be getting to like a goal setting or conversation with folks, just because by nature of outreach, maybe you might be, coming into contact with someone for the first time and you might not ever see them again, right? And so you might not be able to necessarily have that goal setting conversation. But in general, you can still kind of listen to the client about what their needs are in that moment, and then, utilize that flexible array of interventions and options for them without judgment. And then along with that is providing information and education, which is what you all have done for this whole time during this, the Health Ambassador Grant Program. And so offering information on all the options, including maybe the option to stay the same, to maintain the status quo, to not change how often or to what extent a person is engaging with the high risk behavior, but really like information on how to maybe reduce harm if that person continues to do what they're doing, right? And then offer information and education on harm reduction strategies and tools like safer sex, STD and STI testing, HIV prevention, safer injection, legal rights and protections, and then finally connecting clients to resources that are available in the community as well. And then Riley touched on this as well. Building community partnerships is, a pillar of harm reduction. And so what that can look like in practice, which we know from speaking to the health ambassadors that, are and were a part of this program, that this is something that you all are doing a lot of, which is, identifying and developing those partnerships with other organizations in your community, so that you can refer people to other services that they might need, and to really expand the the options for the folks that you're coming in contact with during outreach, for what resources they can have access to. So some of those could include medical, dental, and mental health providers, drug and alcohol treatment, STD, STI testing, resources that are targeted towards specific populations. So maybe like youth focused services, and then, syringe exchanges, drug replacement treatments, and other types of treatment options for substance use as well. So finally, we wanted to take a few minutes to hear from you all. Like, it's really cool to see that, most of the folks who are on the call said that they are already utilizing harm reduction approaches in your work or your agency's work. So we'd love to hear from you. And you can either answer one of these questions, all of the questions, but we'd love to hear what is a challenge that you've encountered with implementing harm reduction in your work. What questions do you have around harm reduction? This can be a really good time for us to answer any of those questions, or have other folks maybe share answers to your question. And then maybe if, during this presentation, you were like, oh, I didn't know that that was a harm reduction approach. What is one new harm reduction approach that you want to implement in your work moving forward? So really, really putting this into action. Would love to hear from folks, and you can come off mute or type in the chat. Yes, Sonja. Sona.
Hello.
Hi.
Yeah, I work for SANE, and we are a syringe services program. So most of the people we serve are actively using drugs, and we just try to provide a loving, stigma-free environment, where they could connect to not only safer use supplies, but also maybe once in this loving, stigma-free environment, they might be compelled to get a test or, an HIV, HCV test, or maybe even connect with our medicated assisted treatment program. One thing I did want to say though is kind of connected to the person first language. One thing that I hear a lot and I see a lot on social media is, and something we always correct when we hear it at SANE, is when people refer to people who use drugs or their past experience using drugs as, or being in recovery as being quote unquote clean. Um, because the opposite of that would be people who are actively using drugs are quote unquote dirty. And we don't want to break down anyone, by labeling them or for them to internalize that they're dirty, because no one needs that. So thank you.
Yeah, thank you so much for sharing that. That's a really good call out. And it is interesting because it seems like also for different folks, different terms mean different things. So maybe somebody who's in recovery wants to call themselves like something, you know what I mean? And then, but for another person, like they don't want to be called that. And so I've heard that as well, that the terminology can really like vary depending on the person too, which just goes to show like honoring people and like how they see themselves and their own experiences, right, is important. Anyone else want to share any challenges or questions or like successes you've had with harm reduction approaches? And then I might say your name very wrong, and I apologize. Please feel free to come off of mute and correct me. Kusar said, we use Narcan and hygiene kits as an approach to start relationship with folks. That's huge. And please feel free to share more about that too, if you'd like if you've run into any challenges with that, or yeah, we'd love to hear it.
Of course. Usually when our case managers or community ambassadors are outside, we have Narcan on us at all times. And folks usually ask for hygiene kits almost every day. At some point throughout the day, they'll ask for a hygiene kit. So that always is a conversation starter.
Yeah. That's great. Thank you so much. And of course, the relationships are everything, right? So that's really great. And we know a lot of the health ambassadors too have told us that they, they're not just like coming up to folks and being like, hey, immediately, like, let's get you vaccinated for COVID, right? Like a lot of folks are coming with other resources, are coming there to build those relationships and just talk to folks and providing water bottles and other supplies that somebody might need, right? In that moment to really, start to have other conversations about other things. So that's definitely a harm reduction approach in practice for sure. Anyone else want to share either in the chat or coming off of mute? I did also want to add just so we did do a very brief kind of or shortened version of this harm reduction training with the health ambassadors during one of our peer network calls. And it was really interesting to hear because we did get to talk about challenges that folks have encountered with implementing harm reduction approaches in their work. And some things that kind of came up that stood out to me were, folks talking about community opposition, right, to harm reduction programs. So I don't remember what the specific, I want to say that it was like a needle exchange program that, folks in the surrounding communities, particularly folks that were housed in that surrounding community, just feeling like being against that. And so that was some of the challenge, one of the challenges that, one of our health ambassadors had shared that they faced. And so I imagine that some of you may face similar challenges with harm reduction approaches, because there's a lot of misconceptions, right, about what harm reduction is. Sarah.
So I have a question about the harm reduction thing. I know that for a lot of people that I work with, there are individuals who have been, I'm just going to say it, clean, right? They've gone through Narcotics Anonymous. They claim that time as their clean time. So it's kind of difficult to, I guess, get them to kind of see it in a different way, right? Like what I've seen with people who are trying to do harm reduction, they'll stop using one way and start using another way, and then kind of sit there and almost just plateau. So what are other individuals' experience with this? Like, how do you guys address that kind of mindset towards it?
Thanks so much for that question, Sarah. Do other folks who are on the call who use harm reduction approaches want to share kind of your approach to that, or how you see that? Yeah, go ahead.
I mean, we really just let them plateau and always have that door open, always have options for them to use safely and stay alive until maybe they do decide to enter treatment or NA, or yeah, that's really the bottom line.
Okay, thank you.
Gotcha. So in that situation, it's sort of it's not sort of it's a harm reduction in the sense you're trying to make sure that folks reduce the harm in whatever behavior they're engaging in, right? Rather than trying to reduce the consumption of the behavior and the substance. But anybody else want to share your thoughts on Sarah's question or anything else?
So using is when it's just a substance. So you're just using. So then when you're recovering from everything, past harms and all that. So you're just stopping the drugs, right? So all the other stuff is going to come up that you have experienced through childhood trauma and all that. And that's something that you work around the 12 step if you're willing to work around that at the time, because sometimes it can bring up some painful things and people will relapse again. Yeah, so yeah.
I like that. Thank you.
Thank you so much for sharing. And then wanted to acknowledge as well a comment in the chat that a challenge is when our lived experiences are triggered to become living experiences. And yeah, thanks for sharing that so much, Randy. Appreciate it. All right. Well, thank you all so much for engaging in this discussion with us. Really appreciate that. I'm going to go ahead and pass it back to Riley to begin our portion of the training on Housing First.
Thank you, Carla. So before we get into talking about Housing First, we do have a poll just to get a quick sense of everyone's comfortability knowledge with Housing First before we dive in, and I will launch that poll now. It should come up in the middle of your screen. So we just want to know, similar to as we asked about harm reduction, your level of familiarity with it, if you are always think about every day, or maybe you've never heard of it. This will help us kind of tailor our conversations for the remaining portion of the training. So we'll give everyone a minute to respond. few responsive have trickled in. I'll share the results soon, but it looks like everyone's kind of all across the board. Some of you are experts in it, some of you have never heard of it, some of you kind of know. So that's great. I think that'll lead to us having some interesting conversations and be able to learn from one another. I'm gonna end the poll and just share the results so you can all see where everyone stands. But I think with that, we'll dive in. All right, so what you need to know is Housing First is a strategy for ending homelessness by getting people experiencing homelessness into housing and staying housed. Your organizations may not have the capacity to provide permanent housing to folks, but Housing First is part of the solution to ending homelessness, and it is also a harm reduction strategy. So in some way, you already probably are engaging with this. So it's kind of, we're going to go over the basics here today and also have some opportunity for conversation. But Housing First, what it is, it's connecting a person who is unhoused with housing first, without barriers to entry, meaning you don't need to stop consumption of substances, you don't need to get a job first. Housing First also means that people get to decide to participate in services once they are in housing. So your housing situation is not dependent on whether you do agree to engage in treatments or engage in certain services. So really, the ideology behind Housing First is that it recognizes that stability comes along with having a permanent home, and there are social benefits housing has on a person's health and well-being. So oftentimes you need a home and you need your basic needs addressed in order to get to a point where you have enough stability to address your substance use challenges. And Housing First also recognizes that homelessness is a housing issue. So Housing First, I mentioned, it's a harm reduction model. And that's really because it's about removing all barriers to receive housing. And it's also a non-coercive approach to, as I mentioned, you don't have to engage in services, but holistic services are offered to help all an individual's needs. But I want to also mention, even though it's a harm reduction model, it's not just for people who are engaging in high risk behaviors, like who have substance use disorders, but for that population, it can be extremely helpful at getting them housed and staying housed. Housing First also, it's required by state law in California in 2016. The state did pass a law requiring all housing programs serving people experiencing homelessness to adopt this Housing First model. And that's because it's evidence-based. Lots of studies have proven that it is really successful at getting people into housing and staying housed. So that's because it's proven to also improve individuals' health and mental health. And it's also known to be cost effective. So the upfront cost of providing housing and services and preventative care at first, that's costly. Those upfront costs can be steep, but eventually people in Housing First programs, it leads them to utilize less emergency services and helps them regain stability, which over time saves communities a lot of money. So on the next slide, we have some information about what Housing First is not, because there's a lot of misunderstandings about Housing First. Some people think of Housing First as just giving people housing and that's it, but really not understanding it's a whole strategy to help individuals overcome an episode of homelessness. And Housing First also isn't housing only. It's services are provided, holistic care is provided, and it recognizes that, again, Housing First, housing is needed to regain stability and autonomy, but supportive services are also needed to help people get back on their feet and address all their needs, not just their housing needs. So some like examples of that is that, case managers and Housing First programs are going to help connect their clients to mainstream benefits they need. That could be like Social Security income or disability income. Case managers will help connect clients to mental health services, help them connect them to employment opportunities, whatever the individual may need and wants to engage in. Also, Housing First, as some of you mentioned, like you're somewhat familiar with it. That's because it's a word that's gained a lot of traction and attention with the general public over the last few years, and some people like to attribute rises in homelessness with the rise in the Housing First model. But Housing First is proven to be a successful approach to ending homelessness. Rises in homelessness more often reflect rising housing prices and limited resources in the homeless system of care. So what's challenging about Housing First is that because of the more intensive support, individualized support it requires, and also the upfront cost of building and providing housing, it does affect, with limited amount of resources, it does lead to longer waiting lists and affects the capacity to serve people if not enough funding and resources are provided in the community to meet the need of individuals experiencing homelessness. On the next slide, just want to take a moment to acknowledge how there are really equitable impacts of Housing First. So what Housing First does is it ensures that the most marginalized and vulnerable individuals that face systemic barriers and discrimination are not further marginalized by eligibility requirements or exclusionary practices for housing. It recognizes that everyone, regardless of their background, what they're dealing with, their circumstances, deserves a place to call home. And oftentimes, for example, Black households and Native American households are overrepresented in the unhoused population due to systemic racism and structural barriers. And Housing First can't change who is experiencing homelessness in the first place, but what it can do is not create or sustain any of these barriers outside of the Housing First model. So this is just a really important thing to keep in mind as we're thinking of harm reduction and Housing First. What are its impacts and how does it equitably serve individuals by reducing barriers and kind of meeting people where they're at? On the next slide, just want to recognize that Housing First implementation is largely focused on providing the actual housing and supportive services, but there is a critical role for outreach in Housing First, where you all stand. So the Housing First model really begins at access to the homeless system of care in order to be successful. Essentially, outreach workers, healthcare workers that have a harm reduction approach help remove barriers to access the homeless system of care in the first place, and eventually can help people later down the road access permanent housing supports that are part of the Housing First approach. So these strategies look pretty similar to what already are in place if you are engaging in a harm reduction approach. So these might look similar, but just want to reiterate how they're connected to Housing First. So having trauma-informed care and using motivational interviewing to build trust and relationships with clients is critical for creating access to the system and promoting Housing First. Also, again, Housing First is a harm reduction approach. So by embracing harm reduction, you are supporting Housing First. Also being person-centered is really critical. Using person-first language, accepting a person's experience as their true experience is really critical. Being coordinated with the larger homeless system of care is important to know kind of how your outreach efforts are impacting the larger community and other homeless service providers. Housing navigation is actually something housing outreach workers can help with to address potential barriers to housing and services for clients in the first place. Also understanding that clients can say no multiple times, but they can still be engaged with in the future. Outreach workers also have experience with the communities they're outreaching to, including staff who have lived experience of homelessness, staff who are representative of the community and receive cultural competency training. So that's just to say the advantages of kind of who outreach workers are and who they know in connecting with clients, maybe more so than other providers. And staff, again, can have partnerships with resources in the community. This is kind of connects back to the coordinated element and can help connect people not only to housing, but to other supports like behavioral health programs and get them their basic needs. And then every person is ready for outreach and housing. So having a housing first mindset is recognizing that, there really should be no requirement to go to shelter before permanent housing. Everyone is ready to have housing. And we only have a few minutes left, but on our next slide, we just want to give you all an opportunity to chime in and say, would love to hear how you're thinking your organization is helping implement a housing first model, how it's already supporting the housing first model, and what questions you may have. And love to hear you come off mute or type in the chat, whatever comments and questions you have. Maybe for folks who are newer to this topic, or maybe those who are veterans on this topic, based on the brief conversation of information I just presented, what surprised you? What's standing out right now? That's all right if folks feel maybe they have nothing to add because they know there's only 4 minutes left, but I think we can move on. And obviously, if you have questions or want to talk to Homebase more about this, just out of your own curiosity, or you're kind of looking to expand your agency's capacity and role in your community, we're happy to support you. So wanted to call out that there is a sustainability planning training tomorrow, same time as today, 10 to 11. And the Zoom link is on the slides, but also you likely have received a calendar invite or email about this already. We'd love to see you there. This training, it's really going to be about how organizations and programs can continue to provide services and achieve outcomes that were made possible by this Health Ambassador grant program that we're here for today, but recognizing that the funding period for this is ending. So it's about figuring out how to continue and provide services. And yeah, we'll share some strategies that are helpful to continue exploring and developing a sustainability plan. So we hope you can join us. And then also next week is our final Health Ambassador Program Connection, where we can all gather together on Tuesday, April 9th, 11 to 12. This we really, really hope you can come out, because it might be the last time we get to see your faces unless you reach out to us for individualized support. We're going to be reflecting on your Health Ambassador programs, talking about lessons learned and about this grant program. And there'll also be some important information about kind of closing out your programs, so that we really hope we get to see your faces again too there. And I think that's all from us today. Is there anything else to add, Carla, before we close out?
No, I don't think so. I think you got it all. And, we have some resource slides on here with different links that you'll be able to click on when we send you the slides. Also some information about free SAMHSA training on harm reduction if your organization would like that. But otherwise, yeah, thank you so much for being here.
Thank you all. Have a great day.